Good morning, everyone. Now, we today will have an innovation in the sense that two of our witnesses will be giving evidence at the same time, in the sense that they will both be in the hearing room and will answer questions from Mr. McIntosh, not speaking at the same time, but alternately. I think the plan is that Ms. Dempster will sit on my left,
yes, Lord,
and Dr. Mumford will sit in front of me. And legal representatives, no doubt, will position themselves in such a way as they can see either the screen or the witnesses as they wish.
it's perhaps worth observing, my Lord, that the reason for this is that these are joint report authors, and I'm keen to capture their evidence in one sitting without the inconvenience of having to revisit matters if that became necessary.
Very well. Good morning, Ms. Dempster.
Good morning.
And Dr. Mumford.
Good morning.
Now, as you understand, you're about to be asked questions by Mr. McIntosh. But first, I understand you're both prepared to affirm. First, Ms. Dempster, sitting where you are, would you repeat these words after me? I solemnly, sincerely, and truly
I solemnly, sincerely, and truly
declare and affirm
that
I will tell the truth,
I will tell the truth,
the whole truth,
and
nothing but the truth.
and nothing but the truth.
Thank you, Ms. Dempster. Now, Dr. Mumford, can I ask you to do the same thing? Repeating after me, I solemnly, sincerely, and truly
I solemnly, sincerely, and truly
declare and affirm
that
I will tell the truth,
I will tell the truth,
the whole truth,
and
nothing but the truth.
and nothing but the truth.
The schedule is that you will be giving evidence today and tomorrow. We'll take a coffee break at about 11:30. We'll take a lunch break at 1. However, if during the course of the day you wish to take a break, we can do that. I would hope that you're properly assisted by the microphones positioned in front of you. But could I encourage you both perhaps to speak a little louder, maybe a little slower than you would in conversation? I'm a bit hard of hearing, and I have to say, Dr. Mumford, I found your voice just a little light. The fault is no doubt mine, but I wish to hear what you have to say, as do everyone else in the hearing room. Now, Mr. McIntosh.
Thank you. I just want to take your full names first. Before I do that, I'll perhaps explain how I'm proposing to deal with the two of you at the same time with questions, partially for the benefit of those watching on the YouTube channel, for yourselves, for call participants, and for the person who's taking the transcript of this evidence. In the initial section, I will deal with questions directly to one or either of you, and I will address it accordingly. Once we get past that initial section, where we work our way through your reports, I will effectively direct each question first to one of the two of you and then the other. I will try and use your names in my questions so that the transcript writer can work out who's about to respond. No doubt they will learn your voices. From the point of view of the technical team, if you're coming in to respond to something that your colleague has said, and I will give you always an opportunity to comment on or add to what your colleague has said, I will ask you just sort of, as it were, wait a beat before speaking, because the camera positions and the microphones do need to be switched over. What happens behind the scenes. If at the coffee break you feel that there's anything about this that isn't working, please do report the matter back to our witness support team who've been dealing with you this morning, and that message can be passed back to me so that I can learn from the experience. What I'll do is I'll start off with you, Miss Dempster. I don't take your full name.
Linda June Dempster.
And what's your current occupation, Miss Dempster?
I'm retired.
And what was your occupation before you retired?
A registered nurse. I still know I'm actually on the register, but a registrant.
What was the last role you held as a registered nurse?
In my full-time employment was Head of Infection Control for NHS England.
Thank you. Dr. Mumford, what's your full name?
Sarah Louise Mumford.
And what's your current occupation?
I am Medical Director and Director of Infection Prevention and Control for Maidstone and Tunbridge Wells NHS Trust.
Thank you. Is that the only appointment you hold at the moment?
Yes.
Now, what I want to do first is to just identify, for the purposes of the transcript, your three reports. So we have your main report, which is in Bundle 21, Volume 1, Document 4, page 96, which is dated the 24th of May, 2024. We have your addendum report of the 30th of October, 2024, which is in the same bundle, but it's page 773, Document 11. And we have your Direction 5 response of the 11th of August, 2024, Bundle 21, Volume 6, Document 4, page 118. Where, and that's your response to our questionnaire that we sent you under Direction 5. Dr. Mumford, are you willing to adopt these reports as part of your evidence?
I think we have two small corrections which Ms Dempster has got on our main report.
Well, I'll ask her to deal with them. Miss Dempster.
Yeah, it's just a couple of dates that we had not got correct.
Of course.
So the first one, I've got it as page 7 in our report, but obviously you'll have a different bundle number, won't you? It's under my, the information about me.
Page 104.
Yeah. It's on the 4th bullet, and I actually started that role in January 2015 and not 17.
So that's the second line of the...
Oh, it's corrected there. It's correct. It's
50.
2015 and not 2017.
So it reports that you, in January 2015, you moved to the Trust Development Agency and was the regional IPC for the South of England.
Yes.
Yes. What's the second change?
It's under the, moving on in the document, it's under definitions.
So that's on page 108?
I haven't got it as a bundle number, sorry. It's 9.2 for definitions.
9.2.
Yes. Where we have got the date of the National Infection Control Manual wrong. We had put January 2013, but it's actually 2012.
So it's on page 131. It should be which year?
Should be 2012.
2012. So the 13th of January 2012.
Yes.
Thank you. Well, I'll return to Dr. Mumford in a moment, but Ms Dempster, are you willing to adopt these two reports as part of your evidence? These three reports?
The three, yes.
Yes.
I am.
Dr. Mumford, yourself?
Yes.
Thank you. What I want to start off with for you, Dr. Mumford, is did you have any connection with the Queen Elizabeth Royal Hospital for Children or NHS Greater Glasgow prior to being instructed for this inquiry?
No, I didn't.
In fact, did you have any connection with Infection Prevention Control in Scotland prior to being instructed for this inquiry?
No, I didn't.
Thank you. Ms Dempster, did you have any connection to the Queen Elizabeth Royal Hospital for Children prior to being instructed by the inquiry?
Yes, I did.
And have you addressed that in the main report at page 106 of the bundle?
Yes, I have.
Yes. Now, I want to ask you a couple of questions. Could you explain precisely what work you did do for the independent review other than this site visit?
Prior to the visit, I met with Dr. Fraser, who explained there was infection issues at the hospital, and he asked myself and a microbiologist from another organisation for some general advice, if you like, about what is the role of infection prevention and control, what does a team look like, what would they do, and what would they be expected to do. So we did that, and then we came on a site visit to the Royal Hospital for Children when 2A was actually closed. It was a complete building site, if you like.
You mentioned in the section that the bottom of page 106, that you met Professor Leonard.
Yes, I did.
And it mentions that you met the infection control manager. Who was that?
Sandra Devine.
Right. And prior to that site visit, did you see any documents about the infection control system in Glasgow as it was actually run?
Not particular to GGC. I obviously knew about the National Infection Control Manual, but not individual guidance.
And after the site visit, what connection did you have to the independent review?
When we left the site, myself and the microbiologist, we gave some very high-level feedback because we experienced a very good visit and walked around and met with people and saw the ward 6A where the children were then, and it's just some high-level feedback about what we saw on the day.
Can you remember what the high-level feedback was?
I believe it ought to be very positive. The ward the children were in was clean, and it was a good visit. There was nothing that hit me in the face as being awful or anything. It was.
And can you help us with the date? Because you didn't actually provide the date in this section of your report.
I think it's February 2020.
So just before lockdown?
Yes.
Right.
You said the high-level feedback was positive. I don't know
Yes.
if you explained the content of the high-level.
Yes, what was it that you said to Dr. Fraser and his colleague in this feedback?
Yeah, I have not got access to that email, but I remember writing an email back saying, you know, we'd walked round, the ward we'd been to was clean, it was tidy, the staff we met were very competent and explaining the care of the children very well. We had met with, in the morning, I believe, the estates team who explained the work that had already been undertaken on the water system and on the ward and what they were doing in 2A. Then we did meet with the infection control team, and we then went on a visit round 6A. And I said there was nothing I saw that in my previous roles, I've visited many hospital wards and sites, but there was nothing that I thought concerned me.
Who in the estates team did you meet? Do you remember their names?
I don't remember them. I think I met Professor Steele, but the rest of the room, I cannot remember the names.
And given that you've probably seen a lot of these names mentioned in documents, that hasn't jogged your memory?
Not who actually met that day, no.
No.
Again, if I can just follow this.
Yeah.
If I understand your answer, Ms. Dempster, when you talked about the high-level feedback, you sent one email
Yes.
giving a resume or
Yes.
a summary of what you'd done that day
Yes.
in the visit.
It was literally a bullet point email. And so did my colleague who was the microbiologist, because he'd obviously taken a bit of a different tack when we were there, was talking about prescribing and probably a bit of a difference to the role that I was looking more from an infection prevention control nurse's point of view.
And after sending that email, did you have any further involvement with the independent review?
I think after the visit, we did actually see the draft section. There's some of the section on IPC and of the report. That was all I saw.
Did you make any comments on it?
I think I might have done, but I cannot swear on that what I did or said.
You can't remember?
No, and I have no access. It's not that I don't know. I can't check back because that was when I was working in my previous role, so everything was via my NHS mail, which I don't have access to.
And do you understand why it was that you stopped any further involvement other than reviewing that draft section?
I understand it was because our piece of work was completed.
Right. In respect of the other section that's mentioned in your declaration, which is your work for the case notes review,
Yes.
you've described that in the third bullet point on page 107.
Mm-hmm.
Now, we can obviously read that, but it occurred to me that we should probably connect your explanation there to the case notes review process map, which is in bundle 6, document 38 at page 1015. Now, this is figure 3.2, if I've got the page right, of the case notes review overview report from March 2021. Now, we had some evidence from Professor Stevens and Gaynor Evans and Professor Wilcox about how this worked. But can you explain where you fitted into the process, either by using this figure, or if it's not helpful, just by explaining more where you fit into the generation of data and the discussions?
Yeah, so my role was to look at either Professor Stevens or Mark or Wilcox or Gaynor Evans would say we're looking at a period of time, maybe a cluster of infections. then I would look at the information that was provided about that period of time. So somebody from Health Protection Scotland, I believe, would then provide me with, well, it was on a system, we had it all on an electronic system, with information about the ward at that time. So it might be the IMT, the PAG, infection prevention and control audits, cleaning audits, estates issues. Then I would be looking at that information to provide some feedback upon what was found.
So the individual documents were grouped chronologically and by place, and you looked at particular ones that seemed relevant.
Yes.
And so do you perhaps fit into the data synthesis clinical timeline box within the large blue box on the right-hand side of that figure?
Yes, that would be right, because after we'd looked at the information, we would then, there was regular meetings held, weekly meetings, and then I would give that feedback to the group of us that met.
And would you have produced reports, or would you have filled in elements of their pro forma? Or was that other people who did that?
I honestly can't remember filling in a pro forma.
Well, why don't we just, to be absolutely sure,
Yeah.
just look at the pro forma, which is on page 1109. And this is the data synthesis template. And there's a data set. I'll show you the whole thing and I'll ask you a question. Then there's a summary page, which we're told, next page, which we're told involves more information from various data sorts. And you see that the fourth whole row across is IMT and PAG minutes.
Mm-hmm.
And I just wonder whether you might have entered data into any parts of these forms.
I don't think I did, no.
Right.
Definitely.
We've heard evidence from the 3 expert panel members that they would meet together to discuss each individual infection and reach a conclusion, and they did this multiple times. Were you involved in those meetings?
No.
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 When you were reviewing the material in order to do the task you described, would you have had anything other than contemporaneous records from the time to look at?
No.
So it'd be IMT, PAGs, audits, cleanings, rules.
Sorry, I'm interrupting you. Somebody did pull out any information that was available on the ICNet system as well. So we would look at any comments that had been made by the infection prevention and control team who may have done a visit to the ward or...
Would you have looked at emails?
No.
Would you have looked at S-bars?
I don't remember an S-bar, no.
Okay, thank you. Well, what I want to do now is to ask you both a simple question. I'll start with you, Ms. Dempster. Is conscious that your views and opinions have developed during the productions of these documents, and we'll discuss these changes in evidence, are you prepared to adopt the final version of your reports as setting out your opinions and part of your evidence?
Yes, I am.
Yes. And same question for you, Dr. Mumford.
Yes, I am.
Thank you. Now, Dr. Mumford.
Mr. McIntosh, if you're leaving Ms. Dempster's
I am, Lord, yes.
involvement with the case note review, can I just ask you about the way you formulated the 4th bullet point on the page we've been looking at? You've been asked to look at the 3rd bullet point.
I think, Lord, her evidence was that she hadn't.
So,
do you mean on page 107?
107 on
All right,
our
I was looking at the other page.
on 107 on our copy.
Yes.
Yeah. There's a reference to I attended regular meetings. Now, the word regular is used fairly loosely. How many meetings? I mean,
Oh, but
or roughly how many
they were
meetings?
weekly meetings. So for the duration of the work I had with
Over what period of time? Roughly,
a few months.
a few months.
Yeah.
So weekly meeting over a period of a few months.
Yes.
Right. Thank you.
Thank you, my lord. What I want to do, Dr. Mumford, is to ask you about your visits to the hospital that have been arranged by the inquiry. I wonder how many times you visited the hospital.
And we visited once
And when did you make that visit?
in March 2023.
Who from amongst the inquiry's experts was with you on that visit?
Mrs. Dempster and Jimmy Walker.
And what parts of the hospital did you see?
So we did a general kind of tour just to get the layout of the hospitals. We visited a ward which was the cystic fibrosis ward. I can't remember.
On the
number.
7th floor, perhaps?
Yeah. And we went to 2A, 2B, because that was open at that point. And we also looked at other areas within the children's hospital. I think we went to the cinema, for example, and we went to another children's ward. And then we also went up to at least 2 plant rooms and looked around those.
Do you recollect whether those plant rooms were up on the 12th floor of the main tower or part of the children's hospital?
So one of them was the new plant room for 2A, 2B.
Right.
And the other one, I cannot remember where that one was.
And with whom did you speak on the visit?
So we had meetings with several groups of staff. There was a group of infection control and microbiology. There was a corporate group, which was board members and other corporate roles. There was a meeting with estates and facilities. And there was another meeting, which was... the clinical team.
So if we could work through that in reverse order. In the clinical team meeting, do you recollect who was in that meeting? Was, for example, Professor Gibson present?
She was.
Any members of the other members of the paediatric mental-oncology clinical team, as far as you can recollect?
There were, and I cannot remember their names, I'm afraid.
Were there
without
any
checking.
non-paediatric clinicians who were present in that meeting?
I don't think so.
When it comes to the estates team, do you recollect who was in the meeting from estates? Obviously, we've heard evidence from lots of people and read about their names. Can you help us who was present in that meeting?
I haven't got the list that we met with me, but certainly the director of estates at the time was there.
That's Professor Steele.
And there was somebody who was responsible for water, somebody who was responsible for ventilation, but beyond that, I can't remember.
And when it comes to the corporate team, do you recollect who was in the meeting for the corporate team?
There was lots of people in the corporate meeting. So the chief executive was there, Dr. Armstrong was there, we had the comms director, we had, I think Professor Leonard came to that one as well as the micro and IPT one. There was the operating officer.
Mr. Archibald?
I think he was there.
Yes.
So there was a good spread of the corporate team.
And when it comes to the infection prevention control team, who was there?
Professor Leonard, Dominic Chaput, who gave a presentation to us.
Are these the presentations we've seen in the bundles?
Yes.
Right.
And other microbiologists, and I can't remember who they were. The people we didn't meet were Dr. Inkster and Dr. Peters.
I'm going to just turn to Ms. Dempster. Can you recollect any of the other names of people present other than the ones that Dr. Mumford has just described?
I remember Sandra Devine was at the meeting for
With the infection prevention control meeting, right?
And I can't remember what meeting we were with, but there was the lead nurse for the unit was there, wasn't there? And
Ms. Rogers?
In the clinical.
yeah, in the clinical.
Would that be Ms. Rogers?
Yes.
Right. Now, starting with you, I'll return to Dr. Mumford in a moment. Ms. Dempster, in the infection prevention control meeting, was there in some form of presentation, or broadly what information was imparted to you?
what we had gone with was some questions for them as well, some semi-structured questions. I haven't brought them with us, and we asked some questions about what had been going on. Could they explain what had been happening and where we were at now, kind of thing, where they were at now.
Right.
And then we did have a long presentation on the water results.
From Dr. Chaput,
Yes,
which is the one we see in the bundles.
yes, yeah.
And in the corporate meeting, do you recollect whether there was a presentation or whether there was an attempt to impart information to you?
It was there was a two-way discussion in the meeting, and I remember particularly at the end, Sarah got up, Dr. Mumford asked for feedback from each of the people at the meeting about anything, sort of learning and how, things had gone. And it was very forthcoming, I felt, at the time. We were given a lot of...
Is any particular bits of that feedback relevant to the subject of your report?
No, well, I think there was one thing that we did pick up on when we were there. We had asked about training about water safety, and that's probably the key piece that we asked for a bit more information on about, was the cleaning of sinks, and the team at GGC offered an SOP. They would send us the SOP about how the sinks were now cleaned, and about training for staff other than estate staff on knowing about flushing of water outlets and the practicalities of working.
And then when it came to the estates meeting, do you remember what information was being imparted to you there?
I think it was mainly a summary of the work that had been completed, but there's nothing that actually really sticks out in my mind, if that makes sense.
And then when it comes to the final meeting with clinicians, do you remember anything from Professor Gibson and her colleagues about their views that seems that sticks out to you?
I think it was the discussion about how difficult it had been for this team of the clinicians, the staff working in that area, and obviously the children and the families, how difficult the time had been, and the difficulties of moving to a different area and the consequences.
Dr. Mums, anything you want to add to those observations about what was said in the meetings?
I think from the clinical team, they were very keen to share with us how pleased they were with the new facility and how the infection rates had gone down, and that was very striking from their point of view. I think from the corporate team, I asked them for their reflections on the events since the move into the hospital, and I think it was clear that it had been a difficult time for everybody involved. There was no... they didn't say anything controversial or critical.
Is there anything... Could you explain, perhaps, for the benefit of the inquiry, why... and to be fair, we didn't ask you to do this, but this is prompted by questions from some core participants, is why you haven't set out in detail this meeting in your report. Is there a particular reason for that?
I don't think that we gleaned any information from the visit, apart from what Dr. Walker found visiting the plant rooms, which, it's not our area of expertise how a plant room works, although it was very interesting for us to kind of understand a little bit of it. I don't think any of it was not available to us in any other form. And so we concentrated on the documentary evidence.
Ms. Dempster, is there anything you add to that explanation of why a detailed narrative of these meetings isn't in your report?
Well, I don't think the aim of us we never went there with the ambition of writing a report about going there.
Right.
We went to see the hospital, to see the wards, to see what was going on. I think it's sometimes if you're just reading papers and you haven't been to a hospital, a ward, to actually visualise where you are is really important to understand the issues, and I think that really helped.
Is there any aspect of the visualisations that you might say you'd only have acquired by visiting? things that stand out for you that you really only understood because you visited?
I think if I hadn't been before, it's a big new hospital. It was a big facility, and I think the size of the plant rooms, for somebody who doesn't spend all their life in plant rooms, and to understand chlorine dioxide and dosing machines, and probably didn't need to know that, but it gives an understanding of the scale and complexity of the issues.
Dr. Mumford, is there anything you'd want to add to that comment about what you gathered by visiting as opposed to, and seeing it as opposed to speaking to people?
I think when we were in the ward areas, it was quite striking that there was still a lot of point of use filters around. We were noticed on the cystic fibrosis ward that they were still using bottled water rather than tap water. We also had the opportunity to try out some of the new sinks and the new taps, and to observe the lack of splash and the difference that had made. But beyond that, I think it was just getting an overall view of the facilities actually made it real in our minds.
Thank you. What I'm proposing to do now is to turn on to your experience, Dr. Mumford, in healthcare associated infections and prevention, control and management, and I'll do a similar for Ms. Dempster. Now, we obviously have your background and experience set out in part 2 of the report, which is on page 100. And we can read that. But a couple of questions arise based on evidence we've had. And I'd be grateful if you could provide with an explanation of what the role is of a DIPC, DIPC in abbreviations.
So a DIPC, a Director of Infection Prevention and Control, is a statutory role in England and Wales, which was brought into being by the Health and Social Care Act initially of 2008 and then revised in 2015. And the Act also contains the Code of Practice for infection prevention and control, also known as the Hygiene Code. And this is that Act which specified that every registered provider of healthcare in England and Wales has to have a nominated Director of Infection Prevention and Control. What it doesn't do is specify what the job role of that person has to be and what the experience of that person has to be.
Right.
But that person, the Director of Infection Prevention and Control, is responsible for the strategic and operational provision of infection prevention services for their organisation, for monitoring those services, for monitoring healthcare associated infections. They have to produce a compliance statement for the Hygiene Code, which has to be available publicly and updated on an annual basis. And they also have to provide their board with an annual report which covers the activity of the infection prevention control team.
And where do they sit within the organisation? Are they, for example, board member or below that?
They would usually be a board member, but they can be below that.
And what relationship must they have, or do they usually have with the medical director?
So not necessarily any relationship apart from reporting into the board. So if the Director of Infection Prevention and Control was a nurse, then they don't have any line reporting responsibilities to the medical director. What the Hygiene Code specifies is that they must have a direct line of report to the Chief Executive, but they're not necessarily associated or directly reporting into the medical director. And until I became the medical director, I didn't have a direct line in that role of reporting into the medical director. I reported directly into the chief exec.
We've had some evidence that in Greater Glasgow and Clyde, and the impression is given this is conventional in Scotland, but I can't say we've had evidence of that, that not only do individual doctors have organisational line reports through the organisation, they also have a professional line report to the medical director. If a DIPSI is a doctor, would they have a professional line report to the medical director?
Yes, along with every other doctor in the organisation.
Right, so that's not different.
Yeah.
Does a DIPSI have to be a doctor or a nurse?
No.
So they
Ideally, they would be. I don't know of any that are not, but that doesn't mean that it's not laid out in the Act that they have to be a doctor or a nurse.
Do they have to have a professional background in infection prevention control?
No.
And I recognise this question can only be the vaguest answer. Is it conventional for them to do so in hospital trusts?
I think in England and Wales, it is more common for them to be an executive member of the board who doesn't necessarily have any background in infection prevention other than it would usually be a director of nursing or a medical director. Now, other than the level of infection control training that they had gathered during their career, then they don't need to have any more training than that.
You're both a DIPSI and a medical director. Is there a particular reason that's come about in your hospital?
I've been the DIPSI for 17 years. I was brought into the organisation at a difficult time when they'd had a very large C. diff outbreak and a very critical Healthcare Commission report. And I was brought in because I was working in public health at the time. And I was brought in by the then medical director, who I knew from a previous organisation and who I'd worked with previously. And he brought me in as a subject matter expert, and probably because I'm quite bossy, to turn the situation around. So that was how I came to be a DIPSI. At the time, I was also able to join the executive team, and I was started to attend the trust board, and both of those things were because of the seriousness of the situation.
But not because you were necessarily a DIPSI? Not simply because you were a DIPSI, it was the local circumstances?
Oh, no, well, it was the fact that I was the DIPSI that I then joined both the executive and the board, yeah.
And then you became medical director later in different circumstances?
Yeah, I climbed up the hierarchy in medical management.
Now, in your report, you deal with this, I think, on page 116, which is at 3.27, where you report that the communication between the infection prevention control team and the DIPSI is vital, where the DIPSI is not a subject matter expert. What sort of communication what sort of features would a successful communication strategy between a non-subject matter DIPSI and infection prevention control team have?
So I believe that a non-subject matter expert DIPSI has to have a strong subject matter expert deputy who is identified as their deputy. And whether or not that is an infection control nurse or whether it is a doctor, an infection control doctor who would usually be a microbiologist, it probably makes little difference, but they need to have that very strong subject matter expert deputy who can then be that channel between the rest of the team and them and advise them. And it's that advice which is really important. so that, because it's the DIPSI who is speaking to the board, they have to be on top of the subject at that point. So they need a very strong relationship between them and their expert deputy.
I recognise that the Scottish situation is different. We have had a HI infection lead role, and the medical director at Glasgow was the HI infection lead. Are you able to? How should a medical director ensure that they know enough to either in England work with their DIPSI or in Scotland be the head of healthcare infection lead if they're not an infection control subject expert, the medical director? How can a medical director have the necessary knowledge to do that part of their job properly?
I think that's recognised widely in England and Wales as an issue. I think if you hold a role like that, you need to do some professional development on an annual basis related to that role. Quite recently, and I think probably as a result of COVID, there are now DIPSI masterclasses which are being laid on specifically to upskill the DIPSIs.
And what about upskilling medical directors? Is that something that needs to be done as well?
If the medical director is the DIPSI, then yes.
But if the medical director is not the DIPSI,
Yeah.
is it more of an issue or less of an issue?
I don't think so. It depends. It depends who your DIPSI is and whether or not they develop skills and whether they have that strong deputy who can transmit knowledge to them. I think the medical director's role is big, but they're not going to be the person reporting to the board. They could be the person who challenges the DIPSI at board level, at executive level, and therefore needs some knowledge. But whether they need to have really detailed infection prevention knowledge over and above what they would have gathered as part of their working lives as a physician surgeon or whatever their specialty was, I don't think that is absolutely crucial. Okay. It's having the role which is the important thing.
I'd like to move on to the role of a medical director. Now, how long have you been a medical director?
Since January of this year.
So, given that relatively short period of experience, can you explain to me, are you also the responsible officer at your health board?
Yes.
What does that role involve?
So that's a role which is also statutory, and that person is responsible for ensuring that the doctors working in your organisation who are connected to you, and that won't be all of your doctors because some will be trainees who are attached to a deanery responsible officer rather than...
It's perhaps worth explaining what a deanery is at this point.
So doctors in training who are in training programmes.
And this is everything up to consultant, but not consultant?
If they're in a training programme.
So that we would call them registrars?
Yes. Or foundation doctors, or I think probably resident doctors is now the catch-all phrase. So the resident doctors who are in training programmes are attached to a deanery, which is an educational organisation. Usually falls to the dean of that organisation to be their responsible officer. And that's because you can find a conflict of interest between that training role and the working role.
So the responsible officer as the medical director would be the responsible officer for all the consultants and all the staff grade?
And everybody who is locally employed, yeah.
What is the responsibility of a medical director as a responsible officer for those doctors?
So the responsible officer has to ensure that the doctors who are connected to them are fit to practice. And that is done by an annual appraisal, a multi-source feedback on a 5-yearly cycle basis, and knowledge of complaints, incidents, and any other intelligence that you gather about that doctor, and then make recommendations as to whether or not they should be revalidated, which happens once every 5 years.
Now, in respect of issues around the management of infection prevention control in Scotland, how have you acquired your knowledge about how we do things here, as it were, in infection prevention control?
So through the papers that the inquiry has provided to us, and through reading documents like the National Infection Control Manual, and so on. So publicly available documents which have described.
I'm going to turn to Ms. Dempster now and ask you that question first, and then go to some of the other issues. How have you acquired your knowledge of how infection prevention control matters are managed and dealt with in Scotland?
Probably through the links through the National Infection Control Manual, and then you go on to, you end up clicking on the next link and you find out information.
It's a largely web-based system.
Yes, definitely, yeah.
Now,
and on the back of that, there is some of the documents we've been in have described internal structures for GGC, for example.
and so your source is documentary in that respect?
Yes.
Right. I wonder if we can just look at your discussion of your professional background, which is page 104 of the report. And we can obviously read that. What I wanted to understand is you started your career as an infection in general medicine, and then you became an infection control nurse back in the 1990s. What I want to understand is we've heard quite a lot of evidence in Scotland, in Glasgow, particularly from Mr. Walsh, about the things that infection control nurses can't do. Ventilation and water being two things that he's discussed. We've also heard quite a lot of discussion about microbiology and unusual infections. And I wonder if you could help us about how one goes as an infection control nurse from being somebody for whom those statements might be true in the early part of a career to the position you ultimately held in as lead infection control nurse. Well, I'm sort of assuming you probably would be perfectly happy to talk about water and ventilation and microbiology to some extent.
In very general terms, but I would never consider myself to be the expert on the level of somebody like Dr. Walker or, Dr. Bennett. We have as an infection prevention and control nurse, I'm showing my age, I suppose. You used to come across into the profession, if you like, that skill set with some general knowledge. You probably would have been a ward manager or ward sister in those days, so you would have come across with some general managerial responsibility. You've been an experienced nurse. But I think that began to change, certainly in England. I'm sure a similar sort of thing in Scotland is that traditionally now the way in is you come in as a lower graded nurse and you work your way up. So
within infection prevention control?
Yeah, so you might come across as what we would call a band 5 nurse, then you would do some competency-based training, and then you would, once you've met some skills and development, you might then go on to become the band 6 nurse or the band 7. And organisations like the Infection Prevention Society have some good developmental structured training resources that people can follow to help progress.
Because so carry on, please.
I was going to say, so there is the piece about what you learn academically if you go off and do a diploma or a degree, but there's also a wealth of opportunities in whatever organisation you're in to learn more. So my background, I'd worked in intensive care, but I had never worked, for example, in a renal dialysis unit. So I personally then spent time with that speciality to understand more and more. So perhaps that's the way I learn as well. As I said before, I do like to see things to understand the issues.
We've had a lot of evidence from senior nurses. I suppose just to pick four rather, there would be yourself, Ms. Devine, Professor Wallace, Ms. Rankin, Dr. Imrie. All have had different career structures. They haven't fitted through a sort of, we just heard the training system for doctors described relatively concisely. From the point of view of the inquiry, is there anything that you would say sets apart the senior directors and above levels of infection control nurses from their less experienced colleagues? Any particular step in their experience, or something that we can see as what makes you, as it were, different from the people who are leading a team or leading a ward or leading a hospital?
Well, I think, first of all, I did do all of those things, so you probably have moved your way through. But there's also the broader experience. So my career started in a small district general hospital. I worked in the public health laboratory service as it was then. I moved to a primary care trust, which covered GP premises, prison health, dentistry. I moved back to an acute trust, covered a mental health trust. So I think you gain, that would be a bit different in Scotland because many of those things are in one health board, aren't they, anyway? But it's about how you move around. For me, it's about how you gain further experience and you move on to a different area. You probably, wherever you work, there's some core things you do need to understand and know about. So you need to know how infections would spread, what precautions you're going to take if a patient comes in with infection A, B or C. If there's an incident or an outbreak, how are you going to deal with it? So there's some core things that we have. And then some practitioners, infection prevention control practitioners, might decide to go more into the public health side of infection prevention and the wider health of the community. Or they might decide to focus on decontamination, really complex situation around decontamination and water safety and endoscopy. There's so many different things, but I think you have to be very wide-read. And you equally, if you don't know the answer, you have to find somebody who does know the answer. And in complex situations, it's probably about looking outside your organisation for help and support if you need that.
In terms of those looking outside, we've had a lot of evidence, and I think the impression that it's in this organisation been tense at times. What's the relationship that you would consider ideal between microbiologists, those microbiologists who are infection control doctors, and infection control nurses? How's that relationship supposed to work from your point of view?
I think no different to any other professional relationship. You have to be able to work professionally with your colleagues. And in England, we do have designated infection control doctors, but equally any microbiologist who's on call, who's working the weekend, who's, covering, will actually have to be giving infection prevention and control advice if an incident happens when they're covering, if you like, and the infection control doctor's not there. Now, certainly in England, the many infection control teams now work a 7-day week. They're 7-day working, which helps things as well, because historically, infection prevention and control services were a Monday to Friday, and then there was far more out of hours. But we all know there's more out of hours than in hours in any healthcare system. It is about good communication and respectful working for each other. And the microbiologists will have certain expertise, and perhaps a nurse who's recently been working in a clinical area will understand far more about the practicalities of a Hickman line than the consultant microbiologist who's never probably cared for one. So I think it's about working jointly, and that's really important to get joint working and communication.
We've seen various documents, although to be fair, no witness has agreed with this statement, which have suggested that, the documents at least, have suggested that infection prevention control in Greater Glasgow is a nurse-led service. Now, to be fair, Ms. Devine has resolved herself from that, but how would you comment on this concept of infection prevention control being a nurse-led service?
I think every organisation probably has a slightly different structure to their infection prevention and control team, because there's no set model that how many nurses you would have, or how many microbiologists or infection control doctors, or how many antimicrobial pharmacists. So I think people see it as a nurse-led service because in any team there's probably far more nurses than any other speciality. So on a day-to-day basis, working dealing with the issues, visiting the clinical areas, visiting patients, talking with patients, staff. Probably the nurses are doing the bulk of that work. And in all my roles, I've been, even in the acute trust, I've led the team working with microbiologists or pharmacists or estates people.
Thank you. Dr. Mumford, anything else you'd like to add on this relationship between microbiologists and infection control nurses?
I think the relationship has to be close. So wherever I've worked as a microbiologist, we've had the team has been co-located, so they're very close at hand. So you don't have to send an email, you can just pop round the corner and there's your infection control team, which is hugely helpful because those informal chats, oh, we've got this this interesting case, we've got a meningitis, could you pop up and go and have a look at it? The result may well not have come through electronically and landed in the ICNet inbox, but you can talk to people and say, we've got this. So it's got to be a very respectful and close working relationship with a lot of trust involved in it as well. So trust that the microbiologists are going to tell the infection control team things, but also that the infection control team are able and competent to go and deal with that, because microbiologists don't go and do the do by and large. They get involved where there's a tricky problem, where the patient is something unusual and they need to go and have a look, or they need to, or there's a funny rash, or and they go and see the patients, or they would need to go and do a ward round. But the nurses, obviously, Linda said that there's usually a sizable team. They go off to the wards and do the do. They're doing the audits, they're doing the checking on people, and then coming back and saying, actually, could you just go and have a look at this patient? I don't think they're doing very well, and I think they need your input. So there has to be that two-way, close, trusting relationship, and I think it's really important that that is the case.
Right. What I'm proposing to do now is just look at some of the sources of in your report, because obviously your first report precedes a number of other documents, and a couple of documents you haven't mentioned, and I want to see whether you've read them. I won't get into the nitty-gritty of what they mean at this stage. I just want to check that you've actually looked at certain documents. If we can go, please, to page 123 of this bundle. Now, in this section, you have discussed the reports of Mr. Walker and Mr. Poplet and Mr. Bennett's report on ventilation. And I notice, Ms. Dempster, that this section doesn't contain reference to Mr. Poplet's report on water or Mr. Bennett's review of cryptococcus. Am I right in thinking that?
I don't think we'd had those reports at the time that we'd written it, but we have since.
You have read them?
Yes, definitely.
Right, we'll come back to what they might mean later.
Yeah, sorry.
Then the second body of evidence, which is on page 123, in the middle of the page, lists various sources, and 6.7 is the blood culture results. Dr. Mumford, am I right in thinking that's a very, very, very large spreadsheet?
It's a very big spreadsheet, yeah.
And this is the one that's been used by Mr. Mukherjee?
Yes.
Right. We obviously have all the reports by Mr. Mukherjee. That's the quantitative report which you had when he wrote this, his Direction 5 response, his supplementary report, his addendum, and his final chart. Have you seen all those, both of you?
Yes.
There was a document that I want to check that you had seen both of. I think one of them is mentioned in your report. So you mentioned a footnote, Dr. Peters and Ms. Harvey Wood's report, which is bundle 19, document 19, page 143. If we just put that on the screen, of the 10th of October. And that's the one that you mentioned in your footnote, Ms. Dempster?
Yes.
Yes. I want to just check, Dr. Mumford, if you've seen the presentation, which is bundle 27, volume 6, document 9, page 107. Dr. Mumford, is that something you've been through?
Yeah.
Right, thank you. If we go back to your report on page 124, you list the third body of evidence, and obviously most of it is PAG records, IMT records, and SBARs. And then you've got various reports. Now, if we could just look at from 6.14. So the first bullet point there, you have 31, 32, 33, and these are SBARs. Now, if we go on to the next page, please. We then have clinicians whom GGC has relied upon, and external reports. Now, what I want to check there is some things that we've come in since then. When did you first see the presentation by Dr. Kennedy and Ms. Rogers to the IMT, which is Bundle 27, Volume 13, Document 13, page 77? Dr. Mumford, do you remember when you first saw this?
I don't remember the date, but I think it post-dates the report.
Are you aware of Professor Evans's 3 reports of whole genome sequencing? And if you read those, you read those. And Professor Leonard's report on, you read that. I think you've already mentioned Dr. Chaput's reports. Have you considered those in preparing your report?
Yes.
Right. Ms. Dempster, I wonder if you could help us about whether you've seen the HPS GGC situational awareness assessment from, it's dated June 19, but it might be older than that. Bundle 7, Document 5, page 194. And this has an Appendix 4 at page 205. I wonder if that has been included in something you read before the report was produced.
Yes.
Right. I think you were aware of both copies of the 2019 October HPS report.
Yes.
Right. Now, the other one, finally, before we move to external reports, is I think you provided reference in a footnote to Ian Storer and Annette Rankin's draft report in respect of the water contamination incident, which is Bundle 19, Document 21, page 174. So this is a report you've read?
Yes.
Now, Ms. Dempster, NSS wanted to point out that it's a draft report, it's not been finalised. Can you help me about how you used it, what sort of information you gathered from it?
I think reading through it, it just generally gave a summary of the background of what was going on in the organisation.
Did you rely on the opinions expressed by Mr. Storer and Ms. Rankin?
No.
Thank you. We've then got some external reports. You've mentioned the case notes review, the oversight board, and the independent review. I want to just check that the Suzanne Lee report you both refer to is the one I think it is. If we go to Bundle 8, Document 32, page 134. Is this the report that you think you've read from Suzanne Lee?
Yes.
Yeah, thank you. Now, what I want to do now is, before we move on to the substance, is slightly surreal, but this obviously is a public inquiry, it's on video, and you've had the opportunity of watching some of the evidence. And what I'm keen to do is to find out which witnesses you've watched, or in the case of Ms. Dempster, listened to, possibly while doing your gardening.
Yes.
And because it'll help us put their points to you later on. Now, what I have a list here, and I might just go through it, and I'll start with Dr. Mumford, and then I'll come back to you, Ms. Dempster, if that's all right. Did you watch the evidence of Mr. Walsh?
Yes.
Pamela Andes?
Yes.
Annette Rankin?
Yes.
David Stewart?
Yes.
Dr. Peters?
Yes.
Lynn Pritchard?
Yes.
Suzanne Lee?
Yes.
Dr. Deegan?
Yes.
Karen Connolly?
I think I did. Yes.
Professor Dancer?
Yes.
Dr. Crichton?
Yes.
Sandra Devine?
Yes.
Dr. Armstrong?
Yes.
Mr. Mukherjee?
Yes. In part, I didn't get quite to the end of.
In part. Gaynor Evans?
Again, in part, yes.
In part. Professor Wilcox?
Yes.
Professor Stevens?
I watched a very small part of his.
Small part.
Yeah.
Professor Wallace?
I can't remember. I think so.
Is there anybody else I haven't mentioned that you might have watched evidence from?
I don't think so.
Did you watch, for example, any of the estate's witnesses?
No,
No. Professor Steele?
no.
No. Ms Dempster, in terms of listening to people,
I did watch some.
You did watch
and
some?
listened to many, yeah.
Mr Walsh, did you watch?
Yes,
Pamela Yandes,
yes,
Annette Rankin,
yes,
Susan Dodd,
yes,
David Stewart,
yes,
Christine Peters,
yes,
Lynn Pritchard,
yes,
Suzanne Lee,
yes,
Dr Deegan,
yes,
Karen Connolly,
yes,
Professor Dancer,
yes, yeah,
Dr Crichton,
yes,
Sandra Devine,
yes,
Dr Armstrong,
yes,
Mr Mukherjee,
yes,
Gaynor Evans,
yes,
Professor Wilcox,
yes,
Professor Stevens.
yes,
Did you listen to Dr Inkster?
yes.
Did you listen to Dr Inkster, Dr Mumford?
Yes, I did.
Back to Ms Dempster, did you listen to any evidence by Dr Walker, Mr Bennett, or Mr Poplett?
Yes, all of them.
Dr Mumford, did you listen to any of those three?
I've probably the first hour of Dr. Walker, but other than that, no.
No. Okay. That's very helpful. What I want to do now is to turn to chapter 7 of your report, which starts on page 125. Now, the purpose for this is you provided an explanation of what is a relevant infection, but it occurred to me that we've seen in reports a lot of references to groups of microorganisms described sometimes in ways you'd expect, like gram-negative, and sometimes in sort of constructed groups like environmental bacteria. And there are lists of bacteria. And what I'd like to do is to look at these groups and to understand for each of them, and there are quite a few, in each case, 3 questions. To what extent they have the potential to be connected to water or ventilation systems. Secondly, does the group contain microorganisms generally unconnected to the environment in the way when you're normally treating patients, you might meet them through breakthrough from guts or on skin, and so on and so forth. And to what extent you'd expect an association relationship of causation between these infections and contamination in the water system. So there are 3 questions. The first is just a potential connection to ventilation. The second one is, does it contain organisms generally unconnected to the environment? And the third is there any form of feeling that there's an association that often occurs with the environment, particularly water? And I'll walk through each of them in turn. And what I'm proposing to do, since it feels a little microbiologically, is generally direct this to Dr. Mumford and to come back to you to Ms. Dempster on each category, if that's all right. But I will start, Ms. Dempster, with a simple question for you, which is, what do you understand by an unusual microorganism?
It would be one, for me personally, that I hadn't heard of before.
It's as simple as that.
Yeah, then I would need to find out about it. So I think we're talking back to before, when you're working daily in infection prevention and control, there's certain organisms, bugs that you hear of regularly, and you would know what they were, what was the potential for infection, what you needed to do with them. So an unusual one for me would probably be when I needed to think, I don't know what to do with that. What do I need to find out about it?
Do you mean that quite literally, that unusual is something you haven't encountered before?
Probably for me, if I'm working in infection prevention and control, and somebody said there's organism whatever, and I hadn't heard of it before, for me personally, that would be unusual. Whereas perhaps if I was the microbiologist, I would have seen many of these. And I suppose as your experience develops, you get to find out about more and more organisms as you progress.
That raises the question. I mean,
Yeah.
you were eventually head of infection prevention
Yes.
control for NHS England.
Yes.
are you saying that the number of what is unusual microorganism depends on who is asking the question, and therefore a Band 7 infection control nurse might have a different understanding from you at the top of your career?
Yes.
Right. So it's a subjective measurement in your
Yeah.
eyes. Right.
Yeah.
Dr. Mumford, do you have any view of what is an unusual microorganism?
So, as a microbiologist, I think an unusual microorganism would be one that a biomedical scientist comes running out of the lab and saying, guess what we've got? That would make it an unusual one. Secondly, something that is, as Linda says, unusual in that it's not the everyday. So there are certain organisms which so for instance, Neisseria meningitidis, which causes meningococcal meningitis, that's uncommon, but it's not unusual. Everybody knows about it. Kids are being vaccinated against it. I wouldn't call that unusual. Something like a Fusobacterium necrophorum, which is an organism which affects young men and forms cavities in the lungs and abscesses in the lungs, that is unusual because you don't get to see very many of them in your career. It is rare, but it's fully recognised as, if you grow it, you absolutely know what's wrong with that patient immediately. So for me, an unusual one is one that you see growing, that comes as a complete surprise, that it doesn't attach itself to a recognised syndrome, and it's something that, as a microbiologist would make you sit up and go, I'm going to go and see that patient, because that's an interesting one.
Is there anything about the frequency of its occurrence that makes it unusual?
Yes, but as I think you can have something that's really uncommon but not unusual, but then you can have something that's uncommon but is still definitely unusual. And I think that's a tricky. It's a tricky concept because, for instance, if you had some of the environmental ones, which you might recognise absolutely as being environmental, and you recognise it immediately, and you know what it is, that would be unusual in a healthcare setting. So if you had I think it does depend on the setting, and it depends on the situation.
So something that would be not unusual in a drain might be unusual in a tap, and would definitely be unusual in a bloodstream sample.
Yeah.
Right. Does unusual have any connotation of not understood?
It can, I think, particularly with the environmental group of organisms, because some of the very rare ones, there's very little literature on infections related to them. There's very little resource that you can go to help you with treating the patient. And so some of the environmental ones are much more difficult.
If an organism is on a national reporting list, because government or agencies decided to monitor it, does that preclude it from being seen as an unusual microorganism?
I don't think so, because there's a difference between unusual in the UK and unusual in other parts of the world. So, if you had a patient who came back from foreign parts with Ebola, that would be unusual, but it's still on a reportable list.
I suppose there's a risk with this sort of conversation is that one forgets that each of these infections are in a patient. And the way you've just described a biomedical scientist coming in and saying, look what we've got, I suppose for a lawyer, we have a similar thing. You might find an unusual piece of procedure or unusual piece of law being used and be quite interested in it. And that somehow separates from the patient. It becomes geeky or a specialist.
Yeah.
Is there an element of that in it where you haven't seen, just literally, you haven't seen one on a plate before, and it becomes almost a teaching opportunity in some sense?
Yeah.
Is it possible to write down a list of what's an unusual microorganism?
I don't think so, because it depends on the circumstance.
But let's look at some of these lists. We'll start with a nice simple one. If we go to Bundle 7, Document 6, page 214, which is the draft October 2019 HPS report, and if we go to page 219, we see a list. Now we're going to look at all four of these categories in a moment, but I first want to just start with gram-negative bacteria. So firstly, when we read gram-negative bacteria, you've described that's obviously it resulted by the staining they demonstrate.
Mm-hmm.
To what extent does this group have the potential to be connected to water or ventilation systems?
It's too diverse a group to be able to answer that, because there will be members of that group which are environmental organisms.
And when it comes to the question, does this group contain microorganisms generally connected to the environment? That's true, but it's not.
It's true, but it's not the whole story.
So it's therefore, it's too broad a definition.
Yeah.
So I don't even need to ask you, or would you expect an association of a relationship of causation or association between rates of this group and contamination in a water system? Or again, is it too diverse?
Yes, it is. It's far too diverse to be able to say that.
Okay. Let's look at the next one, which is gram-positive bacteria. Now, we've seen that defined there on page 219. Apart from the staining issue, to what extent does this category have the potential to be connected to water or ventilation systems?
There are certainly gram-positive bacteria which are related to, or can be related to, the environment and water. And again, the gram-positive bacteria that aren't are much more numerous than the ones that are. So again, it's too diverse to be able to make a generalised statement.
And in terms of connection to the environment, is there anything that can be said about this group's connection to the environment?
I think the same applies to some extent, but if you look at cross-infection related to environmental contamination, not necessarily from water or ventilation, but from, I've touched you, then I've touched that, and then I've touched that, and I've spread it all around. Gram-positives survive better in that.
So there's a slight element of being associated with dry surfaces.
So yeah, so I think you're more likely to see a gram-positive in a cross-infection episode than you are.
Now, both of these have been included in both HPS sets of reports as categories, and they appear elsewhere quite widely in reports that we've looked at. What are the risks of looking at rates of just gram-negative bacteria in general and trying to draw conclusions?
Well, gram-negative bacteria, contains organisms such as E. coli, which is the most common gram-negative organism that you will see in patient infections, and outweighs others by many times. So if you just look at gram-negative, you won't see the small nuances that could be caused by an environmental organism.
Okay, before we leave these two, Mr. Dempster, is there anything you'd like to add about the utility of looking at rates of gram-negative and gram-positive bacteria in the context of, is there an environmental connection?
No, I agree with what Sarah said.
So what I want to do, before we look at the next two lists, I want to step
Mr.
away.
McIntosh, I'm sure I should know the answer to this, but it occurs to me I don't. You talked about cross-infection from the environment, and this is the context of gram-positives and association with picking it up from hard surfaces. It occurred to me that I don't understand the expression cross-infection in that context. So could you help me with that?
So if you take an organism such as MRSA, so methicillin-resistant Staph aureus, we have all sorts of mechanisms in place to avoid transmitting it from one patient to another. But via something in the environment, such as a contaminated surface or a piece of equipment which becomes contaminated and then isn't cleaned, that would be an example of how you transfer it from one patient to the other, and we would call that cross-infection.
Yeah. Right. And the surface is, as it were, the vector.
Yeah.
Right. Thank you.
Now, what I want to do before the coffee break is just look at Mr. Mukherjee's list and then come back to these two lists here. So I wonder if we can go to Bundle 21, Volume 1. His report is at page 3, but I want to look at page 25. So he provided a summary table of the infections that he was looking at. Now, what role did you, Dr. Mumford, and I'll ask Dr. Dempster in a moment, have in choosing or creating or designing this list in his report?
So this list is based on the positive blood cultures in patients on 2A and 2B. And we only included in the list ones where we had a positive blood culture. And then we went through the list of all of the positive blood cultures and picked out those that are related to the environment.
So when you say those that are related, is that they have a potential to be related or they always are related?
I think those that are recognised as being related or can be related. So things like Klebsiella, obviously that's also in a patient's gut, but we know that it can also be related, be found in the environment.
So it's more that they could be rather than they definitively always were.
Yes, because there's that, in the other reports, there's that, what they call the environmental plus enteric group. So this is our, in that kind of language, our environmental plus enteric list.
Right. And so things are only on the list if they're in the sample list.
Yeah.
And you've sought to only include things that either have an obvious connection to the environment or can have an obvious connection to the environment in the literature.
Yeah.
Did you look at the HPS list when constructing this list, or is this your creation a separate process?
So we created the list, and then I remember that we had a Teams meeting where...
Is this Mr. Mukherjee and Mr. Dempster together?
Yes, and I can't remember if Jimmy was on the call as well or not, but then we had a spreadsheet with our list, the list that we thought it was, and other lists, and we went through, and where there were discrepancies in other lists having something that we didn't have, then we would ask ourselves, did we need to have that organism? Just so that we were confident that we had included everything that we needed to include.
And so does your and Mr. Mukherjee and Mr. Dempster's list, this list here, is this longer than the list used by HPS or similar?
Similar, but I think, to my recollection, each of the other lists have additional ones that didn't appear in the blood culture list,
Right.
And therefore we didn't include them.
Because that's ultimately the final check. It has to be in the blood culture list for Mr. Mukherjee. Right. Why is Aspergillus not on this list? Because there's lots of Aspergillus discussed in PAGs and IMTs, and presumably there were infections.
But not in blood cultures.
Not in blood cultures, right. Why is it that Microbacterium chelonae is not on this list?
Because it's gram-positive and not gram-negative.
And is that the only reason?
Yes, I think so, because we only had, yes, it is the only reason.
Why not include a gram-positive as well into the data set? Is there any particular reason?
Because if you start including gram-positives, then there's more than there's more than just one
You have to include more.
that we would have to look at.
Any particular reason not to do that?
Because I think the emphasis was very much on gram-negative, and that was the lead that we followed.
Is there a particular reason based in the literature or the practice of microbiology that you took that approach?
No.
Why is Cryptococcus neoformans and the other Cryptococcus not on this list? Because if we go on to the next page, we see that fungi are on the list.
Yes. So my recollection is that we didn't have a Cryptococcus. We did. We had Cryptococcus cases, but I don't think we had a blood culture with a Cryptococcus.
Because we know that there was a Cryptococcus case in Ward 6A.
But there was no blood culture, as far as I can remember. But I could stand corrected on that one.
And when it comes to Microbacterium chelonae, was there any issue about the way that these infections were described in the data set?
Well, we later found out that, yes, there was. And there was... So there have been a total of three patients with 4 infections with Microbacterium chelonae. And the second of those 3 patients, their Microbacterium chelonae was not described as Microbacterium chelonae on the database.
Right, and we've had some evidence from Dr. Inks about why that might be. Why is it not something I was aware of until I was constructing these questions, but why is Fusarium not on this list?
Because it's gram-positive.
And why is Mucor not on the list?
Because there were no positive blood cultures.
Right, but you're very much limited to
And
what's
actually, that's true for Fusarium as well, isn't
right. NHS GDC have asked me to ask this question. They're concerned that the Candida infections are included and point out that the majority of these yeast infections would be from commensal flora and not from the environment. Well, firstly, do you agree with that? And secondly, why were they included?
I think the potential for them to be commensal is reasonably high. They were included because we knew that Candida had been identified from shower heads when the shower heads were tested. So that's why they were included.
Is there a risk that by including these yeasts, you're confusing matters and wouldn't be safer just to stick at the gram-negative environmental bacteria?
To some extent, but I think the numbers were sufficiently low that actually it makes little difference in the overall data. And we think they were included in the comparator hospitals data as well.
I mean, what I'm wondering is, if you're going to include Candida, why not include Aspergillus, Fusarium, Mucor, and you've given the answer that they weren't in the sample? Right, okay. How, in Mr. Mukherjee's methodology, which you've had some input into, was the risk that enteric organisms were included, managed in his methodology, and therefore that you were counting infections that had an enteric root within the data set? How was that dealt with by the methodology that he developed with your help?
I don't think I can remember why that they were managed differently, because we included that.
I suppose the question is that you've got a number of these. You mentioned Klebsiella yourself.
Yeah.
You mentioned organisms that can be in the patient's gut.
Yeah.
And we've heard evidence that in circumstances there can be a breakthrough into the patient. And I suppose it's possible as a hypothesis that some of those Klebsiella infections were enteric in that sense, and some of them were environmental. How would you be able to tell? How would his methodology be able to tell the difference?
You can't through the methodology that Sid used. You could only do it with clinical input, and you would need the clinical input from the clinicians caring for the patients in order to be able to distinguish between the two. But interestingly, in all of the IMTs, it was hardly mentioned anywhere that a particular patient was thought to be a translocation rather than related to the environment.
This idea of having the help of clinicians, is that similar or different to the approach taken in the case notes review?
Well, they did, of course, have full access to the case notes, which we didn't have. So they could make some judgment in those cases.
Right. Ms. Dempster, anything you'd like to add about the methodology of Sid's report or the construction of the list before we have our coffee break?
No, I think it's just to go back on what Sarah just said about the case note review was able to look at individual patients, individual children, individual blood cultures, whereas we never set out to do that.
No, we didn't ask you to do that. Well, this might be an appropriate place to have our morning coffee break.
We'll take our coffee break, and I ask you to be back for 5 to 12. Mr. McIntosh.
Thank you, Lord. Dr. Mumford, I wonder if we can just return to Mr. Mukherjee's list, as it were, and just explore the decision not to include gram positives or any gram positives in this list. So I think you said before the break that had a decision been made to include Mycobacterium shaloni, that would have prompted the question of whether you consider including other gram positives. What would the other gram positives have been in broad terms?
Well, off the top of my head, there's one called Chrysiobacterium, which I think is gram positive. There's some cocci. I think there's a rhodococcus. But these are unusual organisms, and I haven't got them on my tip of my tongue, I'm afraid.
I'm just wondering whether the question of whether to include these or not is actually made simpler by the fact that you only include the ones that were found. And might it not have been more sensible, and of course the inquiry didn't challenge you on this when you produced the report, to rather than construct the list from, as it were, first principles, simply to adopt the case notes review list of organisms and study that? Is there any particular reason why you didn't do that?
Well, to some extent we did, but we excluded those ones where we didn't have a positive on 2A, 2B.
But you did have a positive, or at least two positives on 2A, 2B, 4B, 6A of Microbiological shaloni.
But they weren't on. There was one which was on the list, and then there was one which wasn't obviously on the list, and the third case was a skin only, so there wasn't a blood culture related to that either.
And so that's basically your reason you didn't include it?
I don't think it was as clear as that. I mean, it could have come down just to an error, to be honest.
But what were you trying to do in constructing this list?
We were constructing a list which Mr. Mukherjee could use to make comparisons with the comparator hospitals.
So in order to be a successful list, what sort of attributes did it have to have?
So it needs to be comprehensive for where we were. I mean, I can see that there's an argument for just throwing everything into it, but I suspect that could be a little bit unmanageable.
So there's a practicality aspect here as well. Right. What I want to do is go back to bundle 7 and page 214 again, which is the list of infections. Now, you've already mentioned, you were there already, 214, please. And then page 219. Yes. I think, Dr. Mumford, you've already briefly touched on looking at these two lists, the environmental bacteria group and the environmental, including enteric group. If we look at the environmental bacteria group, to what extent does this category have the potential to be connected to the water and or ventilation systems?
So they are all, of the environmental list, are all known to be found in the environment and to be and to flourish in that environment.
And
so related to water, soil, etc.
And to what extent would you expect, or alternatively be surprised, if you found an association or relationship of causation between these bacteria and contaminations in a water system?
I think some of them are more unusual than others, but certainly they are all organisms which have been seen in water contamination.
Right. If we then look at the final group, the environmental, including enteric, which adds in Citrobacter, Enterobacter, Klebsiella, Pantoa, and Serratia. Again, if you look at the whole group of the last two combined, To what extent does that group have the potential to be connected to water or ventilation systems?
Again, they do. Enterobacter, you would expect to find, and to some extent, large extent, Klebsiella as well, you'd expect to find in drains rather than in water supply, preferentially, but all of them could contaminate a water system.
And is there any issues around whether they are associated with infections derived from water systems?
What do you mean by issues?
Well, for example, you've mentioned that Klebsiella can be seen through, also through gut translocation. The same sort of multiple causes, as it were, apply to the others.
So 4 out of the 5 of them, so the Citrobacter, the Enterobacter, Klebsiella and Serratia, are not uncommon in clinical infections. So Citrobacter is Serratia, less common in bloodstream infections. You'd find them more in urinary tract infections. But Enterobacter and Klebsiella, I think you would commonly find them in blood cultures.
I think we probably should come to it later when we get to the data, but I just wondered if a hospital with paediatric oncology patients had a problem with gut translocation infections, would you expect that to have a particular pattern that was in any way different from the pattern of infections around a water system related infection?
I think you would see more of a preponderance of E. coli. Enterobacter, Klebsiella would be, maybe Proteus would be the commoner organisms which you might see.
So these would be mixed in with some other things?
Potentially.
Right. And therefore you would look for the presence or absence of those other things to help determine whether there was a gut translocation problem.
That would be difficult to, the fact that you might find E. coli blood culture and bloodstream infections would not automatically say that's a translocation. It would say this patient has an E. coli infection for whatever reason. It could be based in a urinary tract infection, which would be the commonest source of it. So one doesn't necessarily lead.
No, I suppose it's what I'm trying to get at is that if there's a pattern here that one looks for, if you had to describe the sort of mix of microorganisms you would see in a ward where a gut translocation infections were happening at a higher rate than you would want, what would you see in terms of the sort of mix of microorganisms that were growing in number in that ward?
You would see Enterobacter, E. coli, some Klebsiella, possibly some Proteus, but that would be much less common. Possibly some Pseudomonas.
And can you imagine a scenario where a unit had a higher than hoped for level of gut translocation infections, where you were only seeing the Klebsiella and Enterobacter, you weren't seeing the E. coli?
I think it's possible, but E. coli makes up more of the gut microbiome than any other organism.
Thank you. What I want to do, looking again at the sorts of infections, before I do that, I want to just turn to Ms. Dempster. Is there anything you want to add about this environmental bacteria or environmental including enteric group compared to Dr. Mumford?
No, I don't think so. And I think the bit about gut translocation would be importantly made by the clinician caring for that child.
They would notice.
Yeah, they would be looking and know what was going on. It wouldn't just be, we've got a blood culture positive for this. That their clinical assessment would be key in making that diagnosis. Because
is it possible that in our analysis of these events, I've been listening to infection control doctors and nurses and experts and data scientists, and perhaps the voice of the clinicians of what they're seeing has got a bit quieter?
Yes. I think that is really important. And the bit with me, when we're talking about data, each one of these is a child with a bloodstream infection, as you said earlier on, and they would have been looked at very closely by their clinicians caring for them, the consultant with responsibility for their care at a time when they would have been very sick. So I think a lot of we're looking a bit more black and white than looking at the whole child and the whole clinical scenario that the clinician would have been faced with. And we didn't have that kind of information to make decisions.
But if the clinicians were forming the view that a number of these infections had gut translocation or transfer between gut translocation as a cause, would you have expected to see that information percolating into the IMT and PAG minutes?
Definitely, yes, because they were very well represented at those PAG meetings. So, yeah.
Thank you. What I want to do is go to a little bit earlier in this bundle, which is the earlier HPS report, Appendix 4 of it's dated June 2019 draft, and this is on page 210. No, it's not. It's on page. So if we can pop back to the previous page. No, sorry, 209. And 208, 207, 205. Yes, it was 205, sorry, my mistake. So we have a list here that this earlier report has looked at. And what I want to do first, I think probably Dr. Mumford, is do you see that at the bottom of this page, Staphylococcus has popped into the list? And it's not a category that's examined by the later reports. Is there anything about Staphylococcus that would, from your point of view, encourage you to include it in such analysis or discourage you from including it in such analysis?
I think if you were looking for a water or an environmental cause, you wouldn't include it. If you were looking at central line associated bloodstream infections, you absolutely would, and it might be helpful to pull it out as separately.
Right. If we look at the environmental group that they have constructed here, it seems to be a. How would you compare this to the Mukherjee list?
I think the ones that are on this page it's very similar.
And over the page? No, there's only the list on the top of the page.
Yeah, and some of those we didn't include.
But if you go to 205, please. How would, I mean, is this a shorter list than the Mukherjee list, or?
It is shorter.
It is shorter, right. Again, to what extent does this group, as a group, have the potential to be connected to the water and or ventilation systems?
Oh, absolutely, yes, they would be.
Right, and to what extent does this group contain microorganisms that are generally unconnected to the environment?
None of them are completely unconnected.
Right, and to what extent would you expect there to be an association of relationship of causation between rates of this group of infections and contamination of the water system?
There is potentially association with.
Right.
Yeah.
Now, if we go back to the next page, we then looked at a non-environmental bacteria group. But would you agree with that description, Dr. Mumford, of that being a non-environmental bacteria group? Or would you want to comment on that?
Well, apart from the microbacterium, because obviously some of the non-tuberculous microbacteria are associated with the environment. And Ralltella, I think, and Roseomonas we've found associated. But the rest of them, yeah, I would accept that they're not.
Right. And then fungi appears to be a direct similar read across to your yeast list.
Mm.
I'll have to take that as a yes for the transcript.
Sorry,
yes.
yes.
Right. When you look at the fungi list, I think I want to deal with this now because it's not going to come up again. If we look in this report, and go to page 210, there's a little bit of mention. It's the next page, sorry. I go back one page. I'm going to have to find my note because I think I've got a label wrong.
I think it was on the next page. It's at the
we go-
bottom, second paragraph from the bottom.
Yes, it is. Sorry, it is. That's that final paragraph. So this particular work by HPS appears to have reached the conclusion that comparison of the overall incidence of fungal positive blood cultures before and after the move did not change after the move in either group. That's in its case, 2A, 2B, and the rest of the whole children's hospital.
Mm-hmm.
What I wondered whether, to what extent you would consider this fungal group has an expected association with the environment. And in a sense, whether you were right to include it in Mr. Mukherjee's work.
I think it's difficult. I mean, clearly, Candida was found in the environment. Rhodotorula was found in samples taken from Chilbeam. But they wouldn't be at the top of my list of environmental organisms. Far from it. You wouldn't. It's certainly Candida.
Dr. Mumford, could I?
Sorry.
If, just for my benefit, I mean, it's difficult. You're being asked to look at the screen, therefore you're looking in the wrong direction. But
I think
I'd appreciate it if you would
I'm
put your
sorry.
voice up.
Yes.
Thank you.
I think Candida in particular is an organism which it's very common. It's very common, and it's possibly less associated with the environment than the others.
Right. What I want to do is look at Dr. Kennedy's list. So he produced 2 reports in 2018 and one in 2019, and this is in bundle 6, page 121. And the reason this is the list that he attached as an appendix to his 2018 report. Now I'm going to ask both of you the same set of questions here, which is, if you recollect, I asked this question of Dr. Inkster and a couple of other witnesses. And I'll start with Ms. Dempster. What on this list, I'll ask 2 questions, would you consider to be an unusual microorganism? Remember, someone's got to take a note.
And I can't spell them out without looking. Could I do it the other way and say which?
Which aren't unusual.
Yeah.
That would be perfectly acceptable.
Obviously, Stenotrophus is something.
So that's not unusual.
No. Well, I'm not saying it's okay to have it everywhere, but it's something that people would have heard of. Serratia, people would know about. Maybe not Pontilola, I can't even say the word, but Serratia in its genus, I would have known about, as I would Pseudomonas. And Morganella, Morgani, I would know. Klebsiella, Enterobacter. And Acinetobacters at genus level. It's very hard now because having read so much information with all of these names in, they appear more familiar to me than they probably would have done at the beginning of all this.
Thank you. I'll turn to Dr. Mumford. Dr. Mumford, I've got 2 questions for you. One is, which one of these would you consider to be an unusual bacteria? The other one is, do any of these have a background rate? I remember that question asked of Dr. Inkster. Can we start at the top? And for each one, tell us whether you consider it to be unusual bacteria and whether you consider it to have a background rate. If you remember, there was discussion in 2019 seemingly about whether infections were at a background rate. So for the first one, I'm going to have to ask you to pronounce the first one because I can't do it. Is that an unusual microorganism?
Achromobacter xylosoxidans.
So is that an unusual microorganism?
Is unusual.
And does it have a background rate?
No.
No. And why do you say it doesn't have a background rate? I just in general terms, because if the question's coming up, we should have your logic.
Because you know, in all my experience as a microbiologist, that's one of the ones that you wouldn't see it. You would see it once, twice, 3 times in a career. You wouldn't. It's not causing an infection. You would not see it.
So Acinetobacter
Lewoffi.
is that unusual infection?
It is, but it's not as unusual as the Achromobacter.
And does it have a background rate?
I would say not.
Why do you say that?
Because although you see it from time to time, it's very, very sporadic, and you wouldn't, it would still be unusual.
The next Acinetobacter Singii.
Singii.
Sorry. Is that unusual bacteria?
Yes.
Does it have a background rate?
No.
In fact, any of these, no, I'll leave that, we'll go along. Then, Brev, if you could tell everyone the way, just a simple yes, no, whether they are unusual and don't have a background rate, and then we'll go into detail. So the next one, Brevimondes, is that unusual? Does it have a background rate?
It's unusual, it doesn't have a background rate.
Burkholderia?
Burkholderia is less unusual, but doesn't have a background rate.
And how can it not have a background rate if it's less unusual?
Because if you're seeing 1 or 2 a year, does that count as a background rate? That's the question.
What sort of problems does that throw up?
I think it would depend on your patient population as to whether or not you would see it at all. It would be unusual. You would always look for an environmental source. I think if it had a background rate that was measurable and consistent, but it doesn't.
Right. Sedechia lapegi?
That's very unusual. And I know that because until I read this document, I'd never heard of it.
Right.
Had to look it up.
And no background rate, you're
No
right.
background rate. Chrysobacterium indologenes, unusual. Yes, it's unusual, and no, it doesn't have a background rate.
The next one.
And I assume when we're talking about background rates that we're talking about in humans.
Yes, I mean, what I'm thinking about the context here is that we had evidence that during the September and October period in 2019, there was a view expressed, I think, by Professor Leonard, amongst others, maybe Professor Jones, and I can't recollect, that infection rates in the Ward 6A had reached a background rate. Now, to be fair to them, they weren't doing it species level. But Dr. Inkster, I think, wanted to make the point that there weren't background rates for these infections. And I think it's important that we find out if you disagree or disagree with her. And it seems easier just to walk through it rather than replaying evidence. So in that context, does Comamanonis testosterone, I think you're going to have to pronounce them. Is that unusual, and does it have a background rate?
It is unusual, and it doesn't have a background rate.
Do you want to just walk through them?
Shall I tell you which ones are not unusual?
Yeah, that might be quicker.
That'd be helpful. So Enterobacter cloacae is not unusual and does have a background rate. Klebsiella pneumoniae, not unusual, does have a background rate. Morganella morgani, again, has a background rate, but it is less common.
Right.
But it is recognised, and you would expect to see it. Now, these the 3 Pseudomonases are unusual species of Pseudomonas. So although we say Pseudomonas aeruginosa, common, yes, has background rate, these 4 species, are uncommon and wouldn't have a background rate. Serratia, again, as Linda said, Serratia as a genus, you would see it. It's not uncommon, and it does have a background rate. But Fonticola as a species, unusual, and doesn't.
So within the class, it's unusual.
Yeah.
But having But you could have a background rate for both Serratia and indeed going back Pseudomonas.
Yeah.
That's something you could say
At the genus level,
genus level,
but not at the
not
species level.
right?
And Stenotrophomonas multifilia, not unusual, and does have a background rate.
Thank you. Now, if we look at this whole list, now conscious, we've had evidence this list was written by Dr. Inkster in the early part of 2018 and then used by Dr. Kennedy from then on. To what extent does this list have the potential to be connected to the water or environmental or ventilation systems as a whole?
As a whole, they are all organisms which can be associated with the environment.
And then, does it contain organisms that are generally unconnected to the environment?
It has organisms in it which can cross from or are seen in both human sources and environmental sources, such as the Enterobacter, the Klebsiella, Morganella, as we've discussed. But
And those would be gut translocation cases, and
not
necessarily.
Not necessarily, because they are contaminants of the environment as well, because they're gut organisms. So you can have urinary tract infections, you can have line infections with them if you have poor hygiene or the staff aren't washing their hands or poor practice or whatever. So it's not as clear cut as saying if they're not environmental, then they're gut translocation.
Okay. And to what extent would you expect an association or relationship of causation between this group and contamination in the water system?
Association, yeah.
It's something you might expect.
Yes.
Now, finally, I want to turn to CLABSI as a category. There's been lots of discussion, take this off the screen, but there hasn't ever been a list of which organisms are included in CLABSI rates. We've seen lots of charts of CLABSI rates. Various people have made points in meetings or in evidence about how CLABSI rates were addressed and changed over time. What do you understand to these discussions of CLABSI rates to be measuring? Maybe I'll start with Ms. Dempster.
It's a central line associated bloodstream infection. So there's a person, a child, it could be adults as well, they would look at as well as children, who's got a central line in, so a line that's going right into a big vein in their body. And then when they've got a bloodstream infection, so a blood culture's been taken, the patient's got a bloodstream infection, that's then thought to be related to the line.
Is it actually as simple of you have a bloodstream infection and you have a line, therefore you have a CLABSI infection? Is it really that simple?
No. And that's, again, where it goes back to a bit like the other scenario. You have to look at the patient, excuse me, and assess the patient. It might be. I might have a blood culture taken, and I have got a central line in, but I've got a rip-roaring wound infection, infected hip or something else. So there's an actual identified source of the infection that's not thought to be line-related.
Is there a definition? There's a definition which we have. I'm just finding a few moments confusing myself. If you just allow me for a moment just to find the right definition. We go to bundle 7, go to page 218. Do we have the CLABSI definition here? Are you familiar with that definition, Ms. Dempster?
Yes. Yeah.
Yes. So I read that is, as you said, it has to be a bloodstream infection. They have to have a central line. There has to be not another cause. Mm-hmm. You're nodding again.
Yes, sorry. Yes, yeah.
And from your point of perspective, is the rate of CLABSI infections measuring a particular types of species, or is it measuring this definition?
It's measuring this definition. The definition doesn't give a list of set organisms that they're going to measure. It will be the assessment of the blood culture in the patient to see whether that's line related.
Dr. Mumford, firstly, anything you want to add to that? But secondly, does that have any consequences for the use that one can make of CLABSI rates to understand what's going on in terms of infections in a unit?
I mean, I agree with Linda absolutely about the clinical aspect to this, and it has to be, to label a patient as having a CLABSI, you have to have the full clinical picture. It's not just good enough to have a positive bloodstream infection or a positive blood culture. If you have a group of patients who, in a unit where you do not have any issues with the environmental infection risk, then what you see is an infection. CLABSIs tend to be much more due to staphylococci and other gram-positives rather than the gram-negatives. The gram-negatives would be less common in the group of CLABSI infections.
And why is that?
I think it's we go back to our friend the biofilm, because you can get biofilm developing in central lines in the catheter.
Right.
And the gram-positive, they're skin organisms, so they're right next to the opening in the central line. So if they're going to get in there, that's where they will come from. So that's a much more, so just by the position of the central line, you have a higher risk of a gram-positive than a gram-negative infection. And so based on the sighting of them, you do have that. That's, I think, is why you have that preponderance of gram-positive infections.
So there's some connection between the gram-positive group and the CLABSI list.
Because you don't. It depends if the infection is primarily in the line or primarily something else. Because you can see if you have a translocation of organisms from the gut, it can go and settle inside the cannula, the central line, because it's a foreign body, and therefore it will attract organisms to settle on it, because that's unfortunately what organisms do if you have a bacteremia. So it depends on your primary source, but if your primary source is in the central line, they will tend to be more gram-positive than gram-negative. But if the source is a translocation or a similar event or a urinary tract infection, then it can still colonise and infect the central line.
So the type of species within your CLABSI data can tell you something about what the primary source is?
Yeah.
Right. I wonder if we can look at, within the same volume 7, this time we're looking at the earlier HPS report, Appendix 4, it's figure 4, it's page 211, which we had some evidence about. If we could zoom into the top half of the page. This was discussed by Dr. Imrie. Is this a presentation, Dr. Mumford, that you've come across before, this report?
I've seen it before, yes.
So have you come across this style of presenting data before?
I've not commonly come across it, but I've come across it.
Right. What I wondered is, what do you think is the story that we should take from this figure, which has passage of time from 2013 to late 2018 with the opening of the hospital, that line a third of the way along?
So I think it shows you that in the old hospital, you had a small number of environmental infections with environmental organisms, but that increased when they moved to the RHC.
And do you know anything about the nature of the population of these bloodstream infections that is interesting?
So there is a move to an increased number of the more unusual infections.
And so we can look down that list and remember what you said about what was unusual. And so the only things that are not unusual in there are the Cuprovidius, the Enterobacter, the Klebsiella.
No, the Cuprovidius is
It is unusual, right?
unusual,
Sorry.
yeah.
So the Enterobacter, the Klebsiella, Pseudomonas, and the Serratia.
Yeah, but
Everything
again,
else.
you're looking at genus level rather than species
Of
level,
course.
so you may have unusual species within those.
Within those. Ms. Dempster, anything you want to add to that about looking at this figure and seeing what you see?
I don't think so.
No.
No,
I
thank
wonder
you.
if we can look at a similar, well, a very different presentation, but it's got colour and it has different species. This is a later report. It's page 233. It's the October report in draft. Which we discussed, I think, with Dr. Kennedy, amongst others. Again, Dr. Mumford, is there anything that there seem to be 3 years, York Hill, 2A2B, and then 6A, 4B. What do you draw as conclusions or information from this figure 9 by looking at the mix of species it records?
So you can again see that the mix of organisms and the increased variation in the environmental organisms is very much seen in the 2A, 2B.
That's the middle column.
Middle column, yeah. And then 6A, 4B, you are seeing the more of the organisms that perhaps you might think of as having a background rate, but there are also some more unusual organisms creeping into that list as well.
And those are the ones at the top of the table that aren't labelled.
Yeah, so there's an Achromobacter, there's a Chrysiobacterium, there's an Elizabeth Kingia, for example.
And those are the things without background rates.
Yeah.
Right. Now, what I'm proposing to do now is to move away from looking at the different sources of data and the different species and things to some of the other reports in your chapter 8. I want to discuss, you take it off the screen, please, and go back to your main report in Bundle 21, Volume 1, which is on page 129. Now, from paragraph 8.9 to 8.13, you seem, beyond that, you seem to derive considerable information from Dr. Walker's conclusions. Have I got that right, Dr. Mumford?
Yes.
Do you disagree?
No, so, yeah.
How do you respond, each of you separately, perhaps, to the suggestion that your conclusions are undermined or unsupported because of your heavy reliance on the opinions of Dr. Walker, and particularly what I think NHS-GGC would describe as him setting a rather impossible standard for water contamination that might therefore render unreliable large parts of his conclusions? Dr. Mumford, how would you respond to that as a user of Dr. Walker's report?
I think Dr. Walker is a renowned expert in the area of water and water systems. Part of our instruction from the inquiry was to take into account, when we wrote our report, the other experts' reports, because we're clearly not water experts to the same extent that Dr. Walker is. And so that's what we did. But I think in doing that, I don't feel that it undermines our report in any way, because we took expert evidence and used it, as we did with all the other evidence that we reviewed and considered and put together within our report.
Well, before I come back to Ms. Dempster, that follows the follow-on question is, what additional evidence did you use and rely on about water and water contamination, water systems that you had for you when you wrote your report, beyond Dr. Walker?
Well, we obviously had Dr. Chaput's evidence, and we had, the snippets of information that were in the IMT reports and in the other reports that we've read.
And did you read the DMA Canyon reports of Mr. Watson, the auditing engineer's reports of Mr. Kelly?
Yeah.
Is there anything you want to add to that, Ms. Dempster?
No, I agree, yeah.
What I want to do is turn to you, Ms. Dempster, and ask you about water contamination. And I'll come back to Dr. Mumford. You discuss this a number of different places in your report, and in the executive summary, but perhaps most importantly here when you're discussing Dr. Walker's conclusion. And you have a reportage that his report demonstrates the failing of the system, its maintenance, and how the entire water supply to the hospital outlets became contaminated. And there are various documents that you've referred to in your footnotes, which we can go to if necessary. But you also say, if we jump quickly to page 149, the top of the page, that water testing results, as analysed by NHS-GGC and HPS-HFS, demonstrate the water system was significantly contaminated with multiple organisms throughout the site for a number of years. Now, I don't think NHS-GGC accept that, and I suppose that prompts the question of what's your sources for this? So one of your sources is Dr. Triput's work, I understand that. And is the other source Mr. Storer and Ms. Rankin's work?
Yes, we looked at the discussion in there, but importantly, I think it was what we had seen also. There's those expert reports, but we had seen reports through IMTs, the Water Safety Group, that there was evidence of microorganisms in the water and the potential connection to the children and their bloodstream infections.
So that would have included the Water Technical Group meetings from March, April 2018?
Yes.
The wrap-up for the IMT in the water incident in May 2018?
Yes.
But what standard did you apply to the concept of a water system being contaminated? What do you mean when you say that?
I'm not going to be able to quote the certain levels of what is available in each blood sample, each water sample, but we were talking primarily about bacteria.
Yes, and so I suppose before I come back to Dr. Mumford, is there a standard out there that was in existence at the time, in 15, 16, 17, against which you could measure NHS-GGC? Or are you reaching or understanding in a different way?
Yeah, I don't know what the standard was. I couldn't tell you.
Right, well, I can turn to Dr. Mumford.
No.
Dr. Mumford, when it comes to this statement that it's contaminated, are you reaching that because of a particular standard that GGC had to meet, a failure to meet which requires it to be contaminated, or for some other reasoning process to get to the idea it's contaminated?
So the standards only exist for Legionella and Pseudomonas. There are no standards for other organisms. So I think in judging whether or not something was significantly contaminated, it's knowing that there was a large extent of biofilm, knowing that there was a large number of different organisms isolated from different areas within and different outlets and different parts of the water system over a long period of time, and then relating that back to environmental organisms being seen in children and other patients, because we know that water isn't sterile and we know that it doesn't need to be sterile. But what we do want is for the water to not pose a risk to patients. And if we start seeing infections with organisms that are similar to those which are in the water, and then that becomes an issue.
Would you agree with the statement that contamination is the presence of microorganisms in the water supply of what is deemed acceptable by current guidance at the time of sampling? Do you agree with that definition?
Well, that again only relates to the organisms covered by the current guidance, doesn't it?
We imagine take you back in time and give you the job of being the lead ICD at Glasgow and Clyde. So imagine that you were in a room. Remember Dr. Inkster complaining that people hadn't told her of the DMA Canyon reports? Well, I think she gave evidence that in 2016 16, she was asking questions. And I think she pointed us to a minute of the water safety group, which describes some of the questions she was asking. Imagine you were there in her stead and you asked enough questions to get some answers, and you got answers. And someone from a state said, well, Dr. Mumford, what do you mean? What does it mean to be contaminated? What would you have told them then is the definition of a contaminated water system?
I think I would have said that it is water which contains, because you have to end up being relatively vague about these things, water that contains multiple bacteria to an extent that patients are at risk of infection. And I think the risk of infection was quite well recognised by everybody. But if you had to look at just an overall catch-all, I would say if you're seeing total viable counts, for example, of greater than 500 per 100 mil, then that would be a significant level of bacteria that you wouldn't necessarily want to see in a ward which is housing severely neutropenic patients. So that's just one kind of marker. But as an example, as an overall statement, it would be that the water contains bacteria at levels which represent a risk to patients.
And how would you respond if someone then said, but Dr. Mumford, there's no standard at the moment published by the Scottish Government, or there's no standard in L8?
So then
how would you respond to that?
Then I think you have to go back to the data and you look at, and you have to make it up as you go along, which we do quite a lot in infection control in this kind of situation. So you look at all of your data, you look at where your infections are, and you come to an understanding of what level do you feel is acceptable, and then you make an internal standard. That's the standard that you want to get to, and that's this. In these areas, this is too high. Because we know there isn't a standard, because these things don't happen every day, and so there is no reason to have one.
But if it is a case of, as you say, making it up as you go along, isn't that imposing a hindsight-based standard on Greater Glasgow and Clyde in 2016?
Possibly to some extent, but the fact that the water is contaminated is in document after document after document. All of the not just the IMTs, but the water review group says.
So that's not till 2018.
But they state in many places in all of these reports, the water is contaminated.
If we go back to 2016, so in 2016 we have the Legionella L8 report from 2015, and we have some doubt about whether it's being implemented, and we have Dr. Inkster asking questions in the water safety group. And there's no water safety group for the hospital. And I don't think that there's some doubt about whether there is an appointed authorised person. There's no authorised engineer. And you say at that point, 500 total viable counts, or whatever you just described. How do you respond to the suggestion that you're setting up too high a standard for NHS GGC estates people to meet at that point? It's just not fair. It's benefit of hindsight. How could they possibly know?
So, it's very easy for me to say with the benefit of hindsight, because, but you have to put the safety of the patient first. You have to consider that you are seeing unusual infections in patients with organisms which are environmental. When you have contamination you have organisms which are unusual, isolated from your water. You have to put the patient first. You can't just say, well, there isn't a standard, so there's nothing we can do about it. You have to say, but these patients are being put at risk. What we need to do is mitigate that risk. The way that we can mitigate the risk is by reducing the number of bacteria in the water. So estates team, how are we going to do that? Because they're your experts on the ground if you're not a water expert yourself. This is the, we need to get below where we are now. So let's set ourselves a target and head for that. And then we look again, have we made a difference to those patients? Have we reduced the infection level?
Thank you. I can turn to Ms Dempster.
Yeah, can I just say, and on the back of that as well, if what we read through, the evidence we were given was that GGC did think the water was contaminated because the actions they took, point of use filters, then looked at dosing the system, looked at chlorine, there was lots of interventions put in place.
But that's in 2018.
But starting on the testing, yes, that's what you mean, yeah, I'm talking 2018, yeah.
And so what I'm wondering is, conscious that your earlier evidence that, of course, a lot of the people doing the do in infection control are infection control nurses. We've had a sort of microbiologist perspective on this. If you'd been, I think at this point, Pamela Andes might have been at water safety group meetings. If you'd been in water safety group meetings in 2016, what would you have been saying to the estates people about how they should, the standard to which they should run their water system in that hospital, given that there is no published standard beyond Legionella and Pseudomonas?
I would have then, as probably Sarah alluded to, we would defer to probably our authorised engineer. We would also get another water expert in.
But there wasn't an authorised engineer.
No, but I would have asked the water expert who within an organisation, you've got your internal person who's responsible, then I've always worked with an external water expert as well, whether it be for the water in the ward or if you've got, I don't know, probably the commonest time would be when you're looking at endoscopy and you've got a problem with the levels of microorganisms in water there. So we've always had water
And that
experts.
independent person is the authorising engineer?
Yes, yeah. Because there's in my personal experience, there's always been somebody internal with those expertise as well.
I suppose this is a relevant point before I go into more questions about this, is to pick up the way the water safety group was running, not in 2018, but in 2016. So we heard evidence of Mr. Walsh, and there was evidence which you didn't hear from Mr. Gallagher, Mr. Parry, Mr. Purdon, I think Mr. Bratty at one point, about the water safety group, and we've got its minutes. What role should infection prevention control play in a water safety group?
Well, I think they're there as, I don't want to say the advocate for the patient, they're there about patient safety, because an engineering view might not appreciate the risks that the patients are at. So I would be there looking at the practicalities. If they're talking about, I don't know, turning up the heat, putting really hot water through the system, we'd be looking at the practicalities of that, of the impact on the patient. But if I had concerns, I would be escalating that up to in England, maybe my DIPSI or whoever the exec was, to say that we've got concerns about this.
Do you see any relevance to the questions that I asked of Mr. Walsh about him not attending water safety groups and arranging with Ms. Kane to take the chair permanently? Is the requirement to have the infection control manager or a senior infection control person there important to the balance of the system?
Somebody needs to be there with the expertise in IPC. That might not be the nurse. It might be, classically, it's been microbiologists who I've worked with who are very interested in water, whether it's hydrotherapy pools or, as I said, decontamination. So there would be somebody there. Wouldn't necessarily need to be the nurse.
Right. Now, I've got a question for both of you. So I'll start with you, Ms. Dempster. If we look at your Direction 5 response, which is Bundle 21 of Volume 6, Document 4, at page 124, question 11, you were asked a question about the surveillance established in May 2016 of the water system, based on what was known at the time and the guidance in Appendix 13 of the NPCIM. And you have provided a response that you think that a proactive surveillance of the environmental organisms may have acted as an early warning system, allowed correlation of different organisms which would remain otherwise unconnected. Now, can you provide an example of a health board or an NHS trust that's done something like this, what you're suggesting here? On question 11.
I think all trusts, well, certainly where I've worked, we would be collecting data broader than just a set of alert organisms. We would be looking at infections. If you're thinking of a neonatal intensive care unit, you wouldn't just be counting a tiny number. You would look at the whole of infections.
So you think this standard that you've suggested is something that would be widely applied in England?
Yes.
Right. Mumford, do you have any view on that?
Yeah, I would agree. I mean, it's one thing to count things. It's another to actually look at what you're counting and use that data to make inferences about what might be happening. And I think that's what we try to do, so that we can join the dots and make sure that if there are several of a certain infection, that we can actually join them up and say, actually, do we have a problem here? It's the same way that, you know, when we have say we had an MRSA bacteremia, you don't just say, well, we've got an MRSA bacteremia. You go back and look and see which other patients around do we know have MRSA colonisation, and you use the data that you have in order to be able to inform whether or not you've got an infection, a cross-infection problem.
But I think the concern that's been put by the health board is that you've set a standard here that is...
I don't think it's an unusual ask.
You don't think it's unusual ask?
No.
No.
No, I would take that to be the minimum standard. If you could do above and beyond, then you would.
The next, if you go to question 16 on this document, so if we jump onto page 127, this is about water testing rates. I think you're saying something you've already discussed, Dr. Mumford certainly has. The level of testing during 15-16 following handover would have been based on local risk assessments of the water system to ensure compliance with the guidance at the time, and you've listed what those are. And a minimum water should have been tested for total viable count of Legionella. Outlets tested were laid out in the water safety plan of the building. Routine sonoma testing was not recommended in Scotland at the time. Now, what I want to do is, you've seen a lot of Dr. Chaput's reports, so although you're not Dr. Walker, you know how much water testing was going on in 15-16. To what extent was the amount of water testing that you saw in the Chaput data from 15-16 comparable to, how does it compare to the water testing rates you'd have expected to see in an English hospital in 15?
I'm not sure we had rates of testing. We had rates of we had numbers
of
tests
testing.
done,
I've got
didn't
that.
we? And I think although some of those numbers looked big, you have to take into account that QEUH and RHC are very big, with many outlets, potentially 3 outlets per room, which you see in an all single roomed hospital. And what we didn't see, I think, was the absolute risk-based testing. So, when some of the data showed that there was maybe 2 or 3 water samples taken on the whole of the Schiehallion unit, for example, which isn't going to necessarily be representative of what's going on. And
Might it have been represented in the old style sort of Nightingale ward?
Yeah, I mean, because if you just take one patient's room, when you have the 6-bedded bays or so on, then you take one and it's the environment that affects 6 patients. But in a single roomed environment, you take one sample and it affects one room. So it doesn't give you a fully representative picture of actually what is going on. And they had quite a number of high risk areas that we might call augmented care areas. So the Schehallin unit, the renal unit, the ITU, the PICU, the HDU, theatres and so on, where you would want to do the testing. And I didn't feel that the numbers of tests that were done were representative of the large number of augmented care and risk units that they had in the hospitals.
Dempster, do you have anything to add to that, or from your perspective? Thinking about hospitals you were in England in 2015?
Well, I think I've been into quite a few. There is this bit about it is dependent on the risk that you're facing as well. So I think you think of it has been also upped. You would up your water testing.
When you say the risk, are you thinking of the DMA Canyon report as a sort of indicator?
Well, if that wasn't certainly, if we'd have seen that probably as an infection prevention and control team, there would have been some kind of incident meeting, I'm sure, about decisions around water.
So do you feel there should have been an IPC reaction to the DMA Canyon report?
I would have thought a broader reaction to that 2015 report before occupation of the site.
So we know what didn't happen, but what do you think before lunch should have happened when the 2015 DMA Canyon report was handed over by Mr. Watson's colleague in 2015 in terms of IPC?
I would have expected there to be a whatever you like to call it, our language might be different, but an incident management, an extraordinary meeting to actually look at the report with not just infection prevention, but obviously estates, colleagues and
But that
water
requires them
experts.
to draw it to IPC's attention.
Yes.
Anything you'd like to add to that, Dr. Mumford?
No, I just think so. I think that communication of that report is the thing that was missing, as we all know.
Right. Well, this might be a good time to break for lunch.
We'll take an hour for lunch, and if I could ask you to be back for 2 o'clock. Thank you.
Okay, thank you.
Please stand.